Still signing in ang uban, Doc, but we can start.
Okay. Did you guys receive the notes and the lecture from Henry? Did we all receive the lecture and the notes from Henry?
Yes, Doc.
Yes,
Okay.
Doc.
All right, sige. So today, just like before, no, it is just an application of what you guys have already learned. Same as before. It's very short actually. So if you're participative lang, we can finish this in a few minutes. Is it finals week na ba? Next week?
Yes, Doc.
Exams? Okay, sige. So you'll have more time to study. So our discussion today is about the orbits, the oculoplastic area, no? A little bit of the eyelids and the lacrimal system. So you may have noticed in the lecture, no, it's a little bit different than the rest of the eye. It relates a little bit more to the rest of the body, so a little bit more surgery type. Sige, so let's start for the first case. You guys see the slide na, no? It's on the screen.
Yes,
Yes,
Doc.
Doc.
Okay, sige. So this is our first picture. When we're presented with an imaging radiographic image, this is how we describe it. No, first you let me know the modality, the region, and then which section or level it is. Do you have any volunteers? So modality meaning, is it an ultrasound, an X-ray, a CT scan, an MRI? Okay, good. No, so would you say this is a plain CT scan or is this with contrast? So what CT scan also? That was Jessie, no?
Yes, Doc. Non-contrast.
Okay, good. So how did you know, Jess, na this is a CT scan?
Sa iyang kuan, Doc, sa iyang picture.
What in the picture lets us know that it's a CT scan rather than, say, an MRI or an X-ray? Anyone else? Help Jessie out.
Because Doc, ang bone niya, ang lahi ang color which is white.
Okay, sige. Do you guys have lectures on radiology ba? Diba na siya sa special topics?
Yes, Doc.
Okay, so this should be familiar to us already by now, no? So if it's calcified tissues, best ang CT scan, if not an X-ray. No? If you want cut pictures, then CT scan is best. So I agree with you. This is a CT scan, plain studies, and then what region. So when you read an imaging modality, you have to include also what we're looking at, diba? Orient the audience or the listener as to what it is that you are trying to read. Is it
Coronal section, Doc.
good? Coronal section of what?
I think mga sinuses, Doc, like there's what you call a maxillary.
Good. That is the maxillary sinus. I agree with you. No, also, you also see the ethmoid air cells, correct? But in this case, because it's ophthalmology, we know that this is the orbits, right?
Yes,
So what
Doc.
was the topic? So orbit, and then section or level. So, for example, if you say this is a CT scan of the brain, no, coronal CT scan of the brain. To orient your audience more, you have to say no what level it is or what cut at approximately what segment of this region. So, for example, in this CT scan, I would say it's seen at the retrobulbar region at the level of the optic nerve. So how do I know? No, because it does not show the globe anymore, but it shows the optic nerve in the middle. The circle in the middle that you see there, that's the optic nerve. It's surrounded by the muscle cone made up of your recti muscles. Can you see the belly of the rectus muscles? Yes. Can you see my pointer?
Di lang makita ang pointer, Doc.
Okay, hold on. Okay, optic nerve, and then the muscles. Superior, lateral rectus, medial rectus, inferior rectus. Okay, then the one in the middle is the optic nerve. Claro? Do you guys see the annotation?
Yes, Doc.
Okay, so again, no, if you're asked to identify the radiographic imaging, so you guys are going to be clerks already next year. So this is part of endorsements, no. So you should at least know how to endorse, no. So you saw CT scan, a coronal CT scan, plain studies of the orbit seen in the as a section of the retroorbital region through the optic nerve. Okay. After that, now that we've oriented ourselves, let us try to read, no? Describe what you see that's not normal. So because you have two eyes, you have to include, of course, the laterality. What is not normal here? So Jessie told us that she saw the maxillary sinus. What do we think?
Opacification of the maxillary sinuses.
Okay, there's loss of the aeration, no? So you should have, it should be completely black because it's a sinus, so it's air filled. Good. Anything else?
And also deviation of the nasal septum. Doc.
What's that? Can you say again, please? Was that Christine?
Deviation, Doc, I think, or I'm not mistaken, of the nasal septum.
I'm sorry. I think your background is a little louder than your voice, Munggo. Did you say deviation of the nasal septum?
Sorry, Doc, yes, Doc.
Okay. All right, sige. You just had ENT siguro, so that's why you're focusing more on the ENT side. Let's go with the Ophtha findings. So aside from the opacification of the maxillary sinus, there's something in the maxillary sinus, no? What else is there? Or what is not there?
I-mention na tong opacification, Doc, no?
Yeah, the maxillary sinus, there's loss in the aeration, no? So why do you think there's something in the maxillary sinus? What is different in one side of the face versus the other?
On one side, Doc, we can say na parang completely filled and gray, and the other one is like the black na appearance, Doc, like it is air filled.
Yeah. So why do you think that is?
Maybe a presence of Doc, fluid
Or tissue, no? So
or
is there,
tissue.
are we supposed to have tissue in the maxillary sinus?
No,
So what do you see in the left eye? Oh, I gave you the laterality now, that's the left eye. What do you see in the left eye that is not in the right?
The orbital rim is obliterated, Doc.
Okay, good. You have the right idea, no, but we're not at the level of the rim, remember? This is behind the eye already. So the orbital floor, there is a break in the continuity of the bone in the left eye, correct? So there's a break in the floor. That's why you have prolapse of orbital tissues towards your maxillary sinus. Does that make sense to you guys?
Yes,
Yes.
Doc.
Yes,
Okay,
Doc.
good. So it's just a case of a fracture, no? Okay, next. Hold on, let me get that. Never mind. I can't get it. I don't know how to figure. I can't figure out how to erase that na. We have an 80-year-old male complaining of tearing, pain, and redness in the right eye for 1 year already. First, of course, we start with describing what we see, so we know what is normal and abnormal.
Ang right eye, okay, there is lower eyelid na redness.
Okay, good, no? See, anyone else?
Erythemas swelling Doc in the right eye.
Okay, good. So is that the eyelid, ba? What we see? It's part of the eyelid, yeah, but it's not the skin.
So not quite guro sa conduct sa iyang eyelid, but maybe inside of maybe ang canthus medial.
Remember the parts of our eyelid, no? So we have anterior lamella and the posterior lamella. The posterior lamella includes the palpebral conjunctiva and the tarsus, right? So in this case, what is this? It's part of your notes if you guys bothered to read it.
Ay, dili ni sa eyelid margin, Doc.
Yes, good. Your eyelid margin is not where it's supposed to be, right? Compare your left and your right eye, diba? So your eyelid margin looks like it's outturned. Where are your lashes? It's not flush in your eye anymore, no? Ang eyelid margin.
Yes, Doc.
Okay. So what is that? Try to flip your eyelids down. What's that you see? That's already his exposed palpebral conjunctiva. No, so there is an outward turning of your eyelid margin on the right eye. Okay? Aside from that, there's also mild doses on the right and the left upper eyelids. There's excess skin also. So if we're going to describe everything, might as well. You see the eye bags also on the lower lid and both eyes. So the reason why I know that I can say that there's ptosis is because where is your upper eyelid margin supposed to rest, gani? So you look at your own eyes, no, your upper eyelid margin should rest a little just below the superior limbus. So in this case, it's already resting around the pupillary axis, no? So there's ptosis na, blepharoptosis or the drooping of the eyelids. Okay, what's our impression for this case? I mentioned a few of them already. Give me one.
Ectropion.
Oh. Okay, good, no? So there is ectropion where?
The right lower eyelid, no?
Okay, don't forget always put laterality if you have both right and left sides. For example, your arms, your legs. So you have to mention if it's right arm, right leg, diba? And then your eye also. So what else aside from ectropion right lower lid? I mentioned ganina.
Conjunctivitis, no?
Not really, but I think the redness, the inflammation is because of exposure. Jara, I think you said something.
Same with palpebral conjunctivitis.
Sige, I wouldn't say palpebral conjunctivitis because the conjunctiva is like a whole organ, no? So you can't have inflammation of one segment only unless you have like a scleritis, and you can have segmental scleritis. But if it's conjunctivitis, it's usually the entire thing. But Yeah, you can say it's inflamed because of the exposure, probably. Anything else? What's our other impression here? I mentioned ganina. Where's your upper eyelid supposed to rest? This is also
Ptosis.
very good. This is also a case of bilateral blepharoptosis. Okay? So ptosis in general is a this just means it's grouping, no? So you can have ptosis of other parts of the body, ptosis of the breast, ptosis of the etc., etc. So in this case, you want to be specific, blepharoptosis to indicate that it's ptosis of the eyelids. Okay? Any questions regarding this? We're clear about that. We have the next case. We have a 5-year-old male brought in for redness in the left eye on examination. Visual acuity using the tumbling E chart was 20/30 on the right eye and hand motions on the left eye. So, of course, we start with describing what we see. Quick na, so we'll finish. We're wasting time.
Redness yung sclera, Doc.
Okay. In the left eye,
Just not left eye.
there are injections on the left eye. Yes? Anything else? We're happy with that na? So again, no, describe what you see. Symmetrical brows. There are no lesions, no crusting. You mentioned also the eyelids. The lashes are turned out. There's no loss of lashes, etc., etc. Before you go to the inside, start from the outside going in. So you also did a fundoscopy for this case. On fundoscopy, you noted absence of the red-orange reflex. You see instead a suspicious white lesion behind the lens. So what do you want to do next?
Mag-MRI, Doc.
Okay, good. You want to do an imaging study, no? So aside from an MRI, what else can you get?
CT scan, Doc.
CT scan, good. You can also do a CT scan. Anything else? Yeah, let's say we ordered imaging studies, no? So we did 2 imaging studies. The first one that you see in the middle, that's an ultrasound of the left eye. And then the second one is a CT scan. I'll describe to you the ultrasound na lang, ha? There's a mass seen. So the ultrasound is taken with a probe in front of the eye, no? So if you're looking at it from left to right, the probe rests on the cornea. The white part that you see there is the lens, and then ang vacant na part is the vitreous cavity already. Can you imagine, ra? So in the vitreous cavity, it's supposed to be kuan, diba, clear ra, on the inside. In this case, there is a mass that is seen there attached to the retina. There are areas also of calcification. And then, can somebody read the CT scan below this now? Remember to read the modality, the region, orientation also in the section. Give you 30 seconds to compose your answer.
Doc, there is hyperdense intraocular mass in the left side, Doc, with calcification.
Sige, thank you, Christine. Before we read what you see, you have to tell us what the imaging modality is.
See,
CT scan, Doc.
CT scan, Doc, non-contrast, eggshell view.
Good. This is a non-contrast CT scan of the orbits at what section ganito? Eggshell?
eggshell.
Yes, Doc, eggshell view.
Okay, very good, no? Seen through the level of the middle of the globe siguro, no? Because there's a little bit of the optic nerve. Okay, go ahead, Christine. You were saying something about what you saw?
There is a hyperdense intraocular mass on the left globe, Doc, consistent with calcification in a white light, Doc.
Inside the mass, there's calcification, right? The white part that you see, it looks almost as bright as the bone. Okay, that is a very important finding, no? So, I agree you can do an MRI, but if you just want to screen, no, or if you want to confirm the classifications that you see on ultrasound, it's quite easy to do an ultrasound. No, it's not invasive. It doesn't expose the patient to radiation. So initially, we usually do an ultrasound lang just to check the characteristics. So if we see suspicious calcification, we might go with as either a CT scan or an MRI. An MRI, of course, as you remember, is superior in showing us soft tissue details. So if you were looking at possible metastasis or spread towards the optic nerve, or in terms of monitoring, I'd go with an MRI. But for screening purposes, it's cheaper to do a CT scan. It's also quicker. If you are considering also monitoring, you don't want to do the CT scan repetitively because you'll be exposing the child also to a lot of radiation. Okay. All right. So that's what we see on imaging. So what's our management for this case? We have a 5-year-old male presenting with this clinically, and then on imaging, we see a mass inside the eye with calcification. I think probably now you have some differentials going on in your brain now. Does anyone want to do a biopsy? You want to offer medical treatment, surgical treatment? And then tell me why. Like why you're convinced you have to do that.
Removal of the affected eye, Doc.
Why? So when you propose a surgical management, no, especially something like this, because it's disfiguring and it causes a disability, you have to know your indication, know what is, defend your management.
Removal of the affected eye, Doc. And this is indicated if the tumor is too large and if there is no chance of vision preservation.
So you're considering a tumor.
Yes, Doc.
What tumor?
Retinoblastoma, Doc.
Okay, good. You lead with that, no, because we might not know what it is, right? So we know that retinoblastoma is a pretty aggressive, one of the most common childhood tumors. As a matter of fact, it's the most common intraocular childhood tumor. And then in cases like this, if it's big enough already, then enucleation is the best bet. So there are different surgeries we do for removing the eye as evisceration, enucleation, or exenteration. In this case, what do you want to do? So you will put a pin on that, huh? But see, Christine wants to remove the eye. All right. We have next a 72-year-old male who came in for a non-healing right lower lid wound since a year ago. What do we see on PE?
There is some kind of ulcerations though, on the lower eyelid margin.
Okay, there's an ulceration.
Pigmented, Doc. Pigmented ulceration.
Okay. Sige, we'll organize our thoughts now. There's an ulceration. It's pigmented. Anything else?
With central crusting po, Doc.
Okay, there's also crusting
The eyelashes are matted, Doc.
on the upper lid.
Yes, Doc.
What about on the lower lid?
There are no lashes on the lower lid.
Okay, good. Anything else that you see there?
Erythema ko, Doc, on the lower lip.
Okay, I agree. What else? Does that look like a normal lower
There's
lip?
an ulcer, Doc.
Yeah, there's an ulcer. Good. Aside from the ulcer and there's no lashes, does it look like a normal lid to you guys? Does your eyelid look like this?
No, Doc. No, Doc.
No,
No.
there's something wrong yet in this eyelid. Okay, so when we're describing lesions, remember I told you, no, you have to describe color, the size, the location, the depth, anything else that is significant, no? So in this case, how big do you think it is? And then what is the location? And then the defining characteristics, which could be significant. Okay? So I agree with everything you say, except that you have to define lang further. You have to be a little eloquent also. Okay, you're third year students already. So you have to know how to describe this. So when you're clerks na, when you're doing your drawings and your progress notes, expected na when you're labeling, I would say it probably in the middle of the eyelid, right lower eyelid, no? It involves the margin. So it's extending from the anterior towards the posterior lamella. Maybe it's about 5 by 3 millimeters. The edges are rolled. And then, of course, you have to touch it sometimes, no? I agree with you. It looks ulcerated. There are pigmentary changes. There's loss of eyelashes. You touch if it is hard, if it's fixed, if it's movable, what the characteristics, if it's indurated. Those are all very important. So what are our differential diagnoses in this case? Give at least maybe 3. Or 4.
Start
Squamous cell.
squamous cell carcinoma.
Good. Squamous cell carcinoma is a good differential. What else?
Basal cell
Basal cell.
carcinoma, Doc.
Okay, good. What else?
Melanoma.
Good. Melanoma also, no? Consider also something benign just to mix it up, sad. So maybe a nevus, something like that. Okay, good. Sige. So what's the most common lesion in this case though? On the eyelid?
Basal cell, Doc.
Good. So very good, no? Because you're already thinking about the most common. So when you hear hoofbeats, you think of horses rather than zebra first. Okay, we were mentioning this a while ago. I was telling you to describe it, what you see. So there are alarming characteristics that will kanang let you know that it's a possible malignancy, right? So what are these? We mentioned all of them. No, there's loss of the normal architecture. So normally there's a sharp margin, diba? When you look at your margin, when you look at your eyelid, it looks a little upright. It should be covering at least a little bit of the lower part of your globe. The margins are sharp. There are, what do you see in the margin? There are lashes. At the base of the lashes, there should be meibomian gland, the tops of the meibomian gland, correct? So in this case, you don't identify any of that. So there's loss of normal architecture, normal anatomy. The ulceration is already a red flag. The lack of defined borders, no, it looks irregular. If you touch it, if it's hard and indurated, that is also a red flag. If it's fixed, especially to the deeper tissues, if there are changes in color, if it bleeds, or if it's a non-healing wound, and etc., etc. Yeah, that usually comes out in the examination. I think that's in your notes also. So in this case, what's our management? Anyone?
Surgical excision, Doc, with clear margin.
First, we have to figure out what it is, diba?
Mag full thickness biopsy siya, Doc.
Okay, we'll do a biopsy first. No, you can do an incisional biopsy first, whether it's full thickness, partial thickness, it's up to you, no? Better if you do a full thickness nga incisional biopsy. So the difference between an incision and excision is incision, you're just getting a small sample, right? So I agree with you. Get a small sample first before you plan the wide excision. Why? Because it depends on the result of your initial biopsy, no, that can dictate the size of the, diba you said clear margins, how much of the clear margin of the normal tissue are you gonna remove? Remember, your eyelid is not the same as, say, the skin in your arm. No, it's a highly specialized in the tissue. So if you remove more than that is necessary, it's hard also to reconstruct after. The eyelid plays a very important part in protecting the eye. So if you don't have an eyelid, you're prone for infections, for dryness, you can cause blindness in the patient. So you have to be very careful with how much you'll be allowed to remove, said. So if it's squamous cell carcinoma, how many millimeters versus basal cell carcinoma? And if you're sure at all if it's carcinoma, what if it's benign lang and then you're removing a wide margin na, diba? So you have to make sure nga you can defend your management also. Another thing, if it's a sebaceous cell carcinoma, it's not going to be the same as this, no? Sebaceous gland carcinoma, sorry. So you're not going to do a wide excision alone, right? What's the management for sebaceous carcinoma? It's different, it's not excision, ra. Assignment lang. So I think Dr. Jake's gonna ask you that. It's a very malignant na tumor, no? So we can't just rest on excision for that. So in this case, if we did an initial biopsy already and it turned out to be a squamous cell carcinoma, then I agree with you na we can do a wide excision with surgical margins na about 2 to 3 millimeters na, and then we can reconstruct after. All right? Clear? Any questions regarding this case? Common questions also that comes out in your exam. What are the risk factors? Where does it commonly present? No, and then why in the lower eyelid? Why not on the upper eyelid? Real quick lang, any risk factors that you identify for skin CA?
Chronic sun exposure, Doc.
Very good, sun exposure, no? So it's the upper eyelid is actually less common than the lower eyelid because the upper eyelid is protected by the brow, whereas the lower eyelid usually gets hit by the sunlight more. Anything else? UV exposure.
Fair skin, Doc.
Very good. Fair skin, no? Usually Scandinavian nga descent because they're lighter. Anyone else have an idea? History of smoking still. If you have a previous history of prior skin cancers, then you're at an increased risk for developing further cancers also. Okay, sige. Read up on that lang also. All right, now we have a 2-month-old female brought in for an enlarging left lower eyelid mass noted since 1 week after birth. Our first question is, of course, still to describe what we see. We've emphasized it already. Kindly include the location, the characteristics, possibly the size, but even if it's just an estimate, that's okay. Anyone want to try?
That there's a well-defined bright red elevated lesion on the left lower eyelid, Doc, with an estimated size of maybe 1 cm in diameter.
Okay, very good. Anyone want to add to that? I think that was close to perfect na. Very good, Christine, no? Maybe the proximal location lang also. So when you're describing something circular or round like this, no? You want to give the 2 dimensions at least, 2 or 3 dimensions, no? So I agree, 1 cm, correct? 1 by 0.5 cm siguro? And then it's around the medial third, close to the eyelid margin. Very good, no? Next, what's your impression?
Hemangioma, Doc.
Okay, what kind of hemangioma?
Infantile, Doc.
Okay, infantile capillary hemangioma. Good, because there's another kind of hemangioma, huh? So in this case, what would you like to advise the patient in terms of management?
To do imaging, Doc, like ultrasound, MRI, orbit, to assess the lesion depth of
Okay.
mga orbital involvement.
Okay. The
And
same say we flip the eyelid and then we notice that there's no involvement posteriorly na. It's just on the surface. Sige,
Laser, Doc.
continue. Ninyo, you were saying something. Sorry, Sheen. Let's continue. Let's Ninyo continue first.
Ay, kung walay visual axis compromise, we can just like observe. And if there's a vision threatening, Doc, I think maka-start kita ng oral na propanolol, which is a first line treatment. And also we can consider mga topical na beta blockers for mga superficial na lesions.
Okay, good. So you opt to observe, no? For this? For this case, do you want to observe or treat?
Observe, Doc.
Observe. Yes, Doc.
Yes, because the natural course of the disease is it usually increases no in size in the first few weeks, no. Maximum siguro 9 months anemia. After that, then it starts to regress. Complete regression is possible around the school age ng na time sa child. So pwede rin na to i-observe in this case. Okay, and then you give us the options also. Which brings us to the next case, no? So this is a 1-month-old male brought in for an enlarging left lower lid mass noted since birth. Sige, let's describe what we see here. A little more difficult than the previous one, but you can do it.
Doc, there is a
Go ahead, Christine.
there is a appearingly soft, Doc, and violaceous in color, raised mass with a bluish hue, Doc, approximately 3 to 2 cm in diameter, left lower eyelid, Doc, occupying almost the whole upper eyelid, Doc.
So upper eyelid, no? Okay, aside from the whole upper eyelid, what else is it occupying? It actually looks large enough to occupy the entire socket, right? So it's obstructing the globe. Would you agree?
Yes, Doc.
Sige. So in this case, no, I think Nino will manage it differently na. Sheen, you were saying something about a laser. Why would you want to do a laser for this case?
If in this case, Doc, I'll opt laser. Kasi na siya enough na mas ni penetrate na dito ang tumor, Doc.
Okay, so what's the indication then? The size?
Yes, Doc.
Okay, what are our other indications for intervention?
It obstructs, Doc, the one, Doc, vision, Doc.
Obstruct the visual axis. Very good, no? It's also quite disfiguring na. So what is the risk even if it obstructs the vision? What are we worried about? So what if there's an obstruction? Aside from the baby cannot see. There's what we call a deprivation amblyopia, no? Amblyopia, if you've heard about it before, it's actually the layman's term is lazy eye. It's called lazy eye because the other eye does not develop as well as the good eye, no, because there's something obstructing it. So imagine, like if you had a child with polio, no, so it's the other side, for example, is denervated. So what happens if when the baby develops now? The other side is smaller than the other one. No, it's atrophied. So it's similar to the eye. No, so if the patient is less than 9 years old, and then you have something obstructing the vision, whether it's a mass like this or a cataract, and then the other eye is doing well, then you run the risk of developing lazy eye or amblyopia on the other eye due to deprivation. Okay, so you have to remove this as soon as possible. Otherwise, your other eye will not develop stereopsis. No, so you won't have depth of vision later, and etc. etc. Okay, good. But the first line of treatment is still, what did you say again, Inin?
Beta blocker, Doc, propanolol.
Okay, good. Oral, no, or systemic propanolol. Okay, good. Okay, so this is the important PE finding you should consider is whether it's obstructing the visual axis or not. Okay, any questions regarding that case, Valara? You can ask later on also. Huh? Next case is we have a 36-year-old female, chronic allergic rhinitis, excessive tearing on the left eye noted 3 years prior. There's also swelling and pain on the left medial canthal area for 5 days. And this is the third episode in the past 2 years. So very quickly, describe what you see. Maybe you can describe in your head na lang because it's here naman sa there's swelling, there's a central nga umbilicus. It looks like there's an organized nga abscess area na, no, on this area. Okay, what's our impression and how would we manage this case? What do you guys think?
The case is titus.
Okay, good. It looks like it's an infection or inflammation of the lacrimal sac. What else? Why is there an inflammation of the lacrimal sac here, especially in the history? What's the risk factor na to? Initially, tearing did yung complaint no, before the swelling. This is a recurrent na problem also.
Chronic allergic rhinitis ang risk factor, no?
Yeah, good. Also, the excessive tearing also gives us a hint of something that's going on there. So recall anatomically, no, that what is after the lacrimal sac? It's the nasolacrimal duct, right? So if there's something obstructing the nasolacrimal duct, then this is why, no, because your lacrimal sac drains the tears and the mucus from your eyes regularly. Your eyes continuously produces tears and mucus, and it normally just drains to your nose or it evaporates. So if there's nowhere to drain, and then you have opportunistic infections there, then you can have recurrent infections. So in this case, aside from allergic rhinitis, there is a possible block in the nasolacrimal duct. Okay, so good to note lang what's the difference between tearing and epiphora. Sige lang, that's okay.
For excessive, Doc.
Yes, excessive tearing is there's excess production. Epiphora means there's an overflow. So if you have a patient complaining mangod of tearing, you have to differentiate what the underlying pathology is. Is it more of an excess production? So for example, if you have a patient who has conjunctivitis, so there's excess production of tears and mucus, diba? So that is tearing. If you have a patient rather with a block in the outflow of the lacrimal system, which causes an overflow of the normal production of tears, and that is epiphora. Okay, so it just has to do with what the pathology is. So in general, they're under the blanket of tearing. Okay, see, any questions regarding this case? So we've given examples so far of eyelids, of our orbits. We've had talked a little bit about some tumors, and then some lacrimal system problems, no, and then the positions of the eyelids. So those are the important parts now of the lecture. So other things that you have to take note of In the lecture, you will notice that there's a lot of most commons, in this age group, and etc. So the reason why you have to memorize the most commons and the risk factors is because we want to train you to think of what is common there, so you have differentials when you see the actual patients. Now, so if you have differentials, even if there's a lot of differentials, your diagnostic and your therapeutic management becomes a little bit more narrowed. No? So you don't order unnecessary labs if you have concrete impressions. Na. I think this is the last. All right, so this is a picture of a surgical technique, no, for this particular right eye. Okay, can we tell what this surgical procedure is? Letter E picture gives you a hint.
What is resection, Doc?
What's that?
Mueller resection.
Enucleation, Doc.
Okay, let's talk about Mueller resection first. Mueller resection is Mueller muscle is in the upper eyelid, diba? It's one of the elevators of the upper eyelid. Sige. I'm glad that you brought that up though. But this is, yes, I agree with who answered the second one, Gani?
No, Doc.
Van,
Yes po, Doc.
what was your answer?
Enucleation, Doc.
Okay, good. Enucleation, no. So enucleation differs from evisceration because by the root word itself, no, evisceration means you only remove the viscera, what is inside. Enucleation, you remove the nucleus, meaning you remove the globe and the scleral shell, include the segment of the optic nerve. Versus exenteration, when we say exenteration, we remove everything inside the bony orbit. Sometimes we also remove portions of the bone. So, okay, next question. I'll talk you through the performing lang of this surgical procedure. First, we excise the conjunctiva. No, we keep the conjunctiva and the tenons. Letter A. They're doing a peritomy. Letter B, we are isolating the muscles. So we like to keep the muscles as long as they're not involved because we can actually incorporate the muscles in the implant that we put in. So if we put the implant on the implant looks like a ball also, similar to the globe. So if we put the muscles in the same area, later on, cosmesis of your prosthesis will be better because there's a little bit of movement. So of course, it's not going to move the same as the other eye, but some movement. No, dili kayo siya stationary. Letter D, that's already the severing of the optic nerve. And then you want to get as long a segment of the optic nerve as possible. Letter F, that is what you're left with, some soft tissues, and especially the conjunctiva and the tenon. So the reason why we want to make sure that you have a healthy tenons and conjunctiva is because that is what keeps the implant in. And then lastly is the layered closure. This is already the conjunctiva part. And then the last picture, letter L, that just shows us temporary tarsorrhaphy. So meaning we just close the eyelid temporarily. Then later on, maybe 4 to 6 weeks, we can put the prosthesis already. Okay, next question is, what are the instances where this procedure is indicated? No, so why do we have to know why are there different removals of the eye? So there are different indications. So we were talking a while ago about retinoblastoma, no, and I think somebody said she wants to remove the eye. So in this case, this would be what you would do for that instance. So why? What are the indications?
Primary ocular malignancy, Doc.
Okay, good. So you don't want to do an evisceration if it's an intraocular malignancy because you don't want to leave anything, especially if in your imaging you notice that there's already involvement of the nerve or if there's involvement of the scleral layers. Now, if it's beyond the retina and the choroid, now it's safer to remove the entire globe rather than just scrape off the inside because it's going to cause seeding. Okay, so aside from that, aside from tumors, you have other indications as well. Did you guys read up on it na?
Painful blind eye, Doc.
Okay, good. So, for example, if the patient has had long-standing glaucoma that cannot be controlled by medications anymore, sometimes we do remove the eye lang. What else? So, example, if If you have a patient with trauma and it's very disfigured already, there's no globe to identify na, sometimes we just remove the entire thing. So the risk man good if the eye is open is there's what we call sympathetic ophthalmia. This means kanang murag sometimes when they say matakda ng other eye, there's actually some truth to it because remember, your optic nerve, they're connected posteriorly, in the chiasm. So if there's something going on in the other eye, immunologically, so your body might attack the other eye, so you might lose vision on the good eye na if there is rupture of the globe and on the bad eye. Okay, so those are different indications lang. So depending on what the pathology is also. Okay, do we have any questions so far on the previous text that we discussed? The previous cases and also with the notes that I gave you? Was there any particular case that you want to bring up? Personal experiences? Nothing? Questions?
So far, Doc.
Okay, sige. So that ends our lecture for today. No questions. Just make sure that you study the lecture and also the notes, ha? Okay, good night, everyone. Good luck on your exams.
Thank you, Doc.
Thank you, Doc.
Thank you,
Doc.
Thank you, Doc.
Take it out.